Okay, so on to the third story of how modelers may approach population health challenges. It's already been observed that no modeler works alone and no subject matter expert or policymaker works alone. And so on behalf of a large ReThink Health team and colleagues across the country, I'll tell you a sort of quick glimpse into how we've approached the challenge of regional health reform. And just a word about why that matters. You've seen two examples this morning about tobacco models and air quality, and we can make a list, A to Z, of the health challenges and opportunities that people face. But our data tell us another thing, too, which is that there are regional patterns that transcend the specifics of any disease or body part or physical exposure. And this is true in the way that healthcare is delivered and what it costs. It's also true in the social, economic, environmental conditions that leave people vulnerable to risk and disease and safeguard their health. So it is these sort of, this challenge of addressing regional health reform that groups across the country are beginning to form aspirations that are not just about addressing problems one at a time, but establishing health systems that work more effectively in their sort of aggregate performance. Better health, lower cost, better care for people who need it, greater productivity for healthier, more productive lives. What we set about to do in building the ReThink Health model was to help people who are immersed in these systems to equip them to see themselves and the system that they're a part of and their own roles as change agents. So asking questions about what are the likely health and economic consequences of different approaches to regional health reform, but also recognizing that this has to be done under realistic regional conditions. And you can make your favorite list here. And across this country, there are different dynamics around insurance expansion, demography, and aging and inequity are all in different positions, health status and risk and vulnerabilities, of course, healthcare and its quality and utilization, the infrastructure for meeting demand and supply for different subgroups, all very different, complexities of the economy and its recession and recovery, new kinds of economic incentives that are being formed and who gets paid for what and how resources are devoted to the things that might make a difference. Nobody can keep those dynamics in their head when making choices about what to do. And this is exactly one of the things that we're hoping to do with the model, is to help people keep track of these simultaneous moving pieces as they then ask what-if questions about what can make a difference. The easiest way to explain this model is with a quick 3-minute movie. So let's hit this, and you'll see a quick summary about what this model is and what it does.
The American health system is big, complicated, expensive, and it can be much better than it is. When we think of our health system, most people think of doctors, hospitals, insurance, drugs.
Let's try that one more time.
Patients. But really, anything that affects our health is part of that same system. We all need things like clean air, healthy food, safe neighborhoods, quality education, good jobs. But too many of us don't have these advantages. Behind the scenes, everything has to work well and work together as a system for everyone to be healthy and productive, get the care they need, and keep costs down. The problem is, it doesn't. In fact, many challenges are getting worse. What will it take to change direction? People everywhere are scrambling for solutions. They're trying to expand insurance, deliver better care, cut costs, change payment, and finding ways to create healthier conditions in homes, schools, workplaces, and neighborhoods. Unfortunately, disconnected efforts are rarely strong enough or last long enough to move us where we need to go. And progress in one area can even make things worse somewhere else. We need some help, good data, a shared set of assumptions, the ability to compare scenarios, and the opportunity to imagine a better future. The ReThink Health Dynamics model is just that, a regional health system in a computer. With the model, you can ask what-if questions and get the results instantly to see how various strategies are likely to unfold. Which approaches, alone or in combination, could do the most to save lives, save money, increase quality, and boost productivity? How long might it take? How much would it cost? What are the pitfalls? And how do we do the most with our resources? With a diverse menu of initiatives and financing options, everyone can test their own ideas and track results across scores of measures. It brings together decades of evidence and experience so we can see for ourselves how the health system is structured, where it's headed, and how it responds to our investments. It can even use local data to represent special features in different regions. When all the right people from the region are engaged, we not only learn from the model, but from each other. Conversations become better informed and more creative when we see and feel the consequences of our choices. Together, we can weigh trade-offs, gauge resistance, and craft a compelling scenario, then work to make it real. The model is not a crystal ball or an exact blueprint. It helps to surface assumptions and examine uncertainties, and it continues to evolve and gets better as new research arrives. It creates a safe setting to tackle tough topics and is a powerful tool for those who are serious about moving their health system in a new direction. A healthier future is within reach, but we can't pursue a different path if we can't see it.
So we can go back to the slides. Hopefully you've seen the echoes of what our former speakers have said in terms of our orientation to construct a tool like this. It's meant to be used by people immersed in systems that they don't fully understand and having to make decisions. We constructed this model having sort of synthesized insights and data sources from a couple decades of prior models that have been built at the national level and now trying to extend that to a regional level. We've also did it not from a sort of desk in a lab somewhere, but we sat down with leaders in Pueblo, Colorado who were addressing the regional health reform agenda and together framed an approach to looking at the things that they thought were within their capabilities to influence the region. We then sort of expanded that to 5 other sites within the first year, and then 9 others over the last 3 years. It's also been used, increasingly being incorporated into academic curriculum as future leaders are beginning to think about how the system works and what are some of the conditions under which it might be able to change. I won't go through all of the highlights of this, but just as an example, the National Association of Schools of Public Policy is a network of almost 300 academic institutions across the country, and just a few weeks ago, they held their first student simulation on health policy challenges, and within one day, 200 students across 93 schools sat down to think about how the health system might work and their roles as policy leaders. And so that's an example of the kind of widespread use that's beginning to occur in community settings as well as in academic campuses. Every user of this model is essentially confronting a system challenge, a stewardship challenge. How do we as actors within these systems think about crafting strategies that are going to change performance, not just in the short term, but in an enduring way so that we can begin to sustain these changes over time progressively? There are essentially 3 questions that one asks in the real world and are represented in the model's logic, being specific about what we're going to do, how we're going to pay for that, and critically, how proud would one be of those consequences? And often, many people say, well, if that's all it will accomplish, I don't think we've done enough. I think we need to think more creatively or differently about what it takes to achieve the kind of changes that we think are capable of unlocking health and economic potential. And that leads to an iterative sort of process of exploring under what conditions can we make a difference. The model gives an intentionally sort of unapologetically simplified menu of the thousands of things one could do to change a regional health system, upstream and downstream. We've narrowed that down to a couple dozen of the major areas that have been documented to make a difference in and of themselves, and also that are openly debated as to what extent they're going to make a difference and how much should be invested in them. These span everywhere from a variety of things that can be done to just simply cut the cost of an expensive healthcare enterprise, to increasing the capacity and the quality of the care that's delivered, and quite importantly for this roundtable, the set of behavioral, environmental, public safety, and socioeconomic conditions that strongly shape the health and well-being of people, as well as the risk and vulnerability that sort of drives the demand for expensive downstream healthcare. One can look at these things alone and in combination, and just to give you a quick sort of sense of the kinds of insights that users of this tool have begun to see, we'll look at just 2 quick scenarios. They start with a sort of suite of some of the most promising innovations in clinical care delivery. Imagine this as a suite of strategies that move our overdependence on tertiary care more to primary care, establish medical homes, begin to emphasize the greater adherence to guidelines for preventive services, as well as support for self-care of individuals, and also the elimination of waste that leads to a lot of care that doesn't actually improve health. So that's a sort of combination of things that represent the evolution of sort of downstream care to a more preventive and chronic care orientation. That's one scenario, and we'll add to it a more balanced investment that also addresses opportunities that if one had read the Guide to Community Preventive Services, we would see that there are significant gains that can be made in healthier behaviors and safer environments. And so we'll look at these as a layered scenario. How much can we accomplish with the downstream emphasis, and what can we accomplish with a more balanced emphasis that reaches into the wider areas outside of the clinical arena? And as you heard, right, we got to be specific, not just what do you want to do in some magic wand way, but how are we going to pay for these things? Everything we do in a system there's no free lunch, right? There has to be consequences and realistic constraints involved, and this is what we all confront. So with this scenario, what we've done is use national data, scale it down to represent a population of 300,000 instead of 300 million, and think about financing at a regional level. What kind of resources can one plausibly think of directing toward this kind of work? Well, we start with an initial assumption, all of which can be varied, that we take just 1% of what people are spending in the healthcare enterprise and devote that to invest in the change agenda that we're looking for the reform movement. In this case, that leads. And it's a temporary fund, right? 5 years, 1%. How much can we use to get that to kickstart our agenda? We'll also represent gain-sharing agreements if healthcare costs are lowered. Some fraction of those, in this case a 50-50 split, would come back to reinvest in the endeavor. That's just like a lot of the accountable care community organizations, accountable health communities that are starting to form are pursuing exactly these kinds of gain-sharing agreements in public, in Medicare, Medicaid, and commercial plans. And we'll also begin to move away from a fee-for-service system that has obvious perverse incentives for delivering more and more volume to a payment based on value per capita payments that change endogenous incentives within the system. So we're making some assumptions. Everything about this can be modified directly by the users, but for this morning, we'll just look at these kinds of sort of initial scenarios. And so we'll do this very quickly. The first thing to learn is that downstream investments can deliver pretty fast and focused impact. You could pick almost your favorite variable of clinical care delivery. I just picked urgent events, which is sensitive to the degree to which chronic conditions are well managed, and you can see a pretty quick and sustained impact on urgent events. This also plays out with a little bit more of a time delay into really big measures of the prevalence of severe chronic illness. This is the major driver of disease and cost in the United States and also globally. And you could see a pretty significant decline in this sort of severe symptomatic physical illness. So that's the good news. On the other hand, these downstream investments, as a rule, tend to plateau, and they have mixed effects on cost and equity, right? So we are probably, in this scenario, lowering the dependency on hospital inpatient stays. That's a good news in lowering cost. On the other hand, we're shifting to greater involvement with primary care and preventive and chronic visit, and their utilization and costs and pharmaceutical use are going up. So there's a sort of a net effect of costs going down in some places, going up in others. What's the balance of those? I can't do that in my head. That's exactly why we need computers to play this out against the other changing dynamics in a region. So that's one picture of the downstream. If we add now the upstream investment to it, the emphasis on healthier behaviors and environments, where does that get us? Well, the first headline is this combination can unlock a lot more health and economic potential. These upstream elements, as a general class, have much broader influence on health and cost and equity and productivity. They work much more consistently, but their effects can be very large, but they accumulate gradually. So here we've got in green the combined scenario where it does not plateau but gets stronger and stronger and stronger over decades. There's a little bit of a trade-off in the short term, but for the most part, these are not terribly distinguishable in the first 8 years or so, but then as you have these upstream investments, they play out and accumulate stronger and stronger impacts. And that's true for cost saving as well. If you think about the upstream world, often is thought about as just in promoting health, but it also has powerful economic consequences in lowering total cost of care in a region. So here you see the same kind of pattern, but played out against an economic measure. Just a word or two about what it costs to do this work, right? So these balanced investments are no doubt more expensive to implement, and quite a bit more expensive. Often have a very high upfront price tag that has to be sustained over time. These are not things that you can do and then just back out of quickly. They need to be in place and at a relatively sustained investment level. The good news is that for many places, these sorts of upstream investments, we've had evidence for decades that say that it ought to make a difference. We just haven't been very successful at directing resources to invest in them. And so for most communities, these things are not affordable. One of the insights that we're developing with this model and users across the country are seeing is that when coupled with downstream reforms that deliver gains, now this can be potentially very lucrative. Here you've got a scenario where downstream investments save nearly $1 billion and almost double that return through the gain sharing agreements when you have the upstream investments in place. So it's really a question of when we save money, whose money is that and who's making the decisions on where it goes and how widely are we investing in all the factors that drive health and economic trends. Last thing I'll say about this is that there are pretty powerful forces that are driving healthcare costs up and up and up, and increasingly many places may not be afford not to make these kinds of investments if they are indeed capable of delivering these kinds of cost savings. So there's typically a worse before better pattern in all scenarios where you're making these investments. The question is how fast do you get that yield, and how happy are you with that yield? Are we confident, are we content with sort of a short-term gain that plateaus quickly and gives the yield in the downstream world, or are we looking for the much more progressive, much more lucrative agenda of long-term change? In either case, you've got powerful economic sort of signals that say this is probably worth it, but there's a trade-off and a choice about which strategy to pursue. That's also true if you look beyond the healthcare costs and think about the productivity of the regional economy. Same sort of story. If you're trying to sort of expand productivity of the healthcare workforce and you net out the healthcare costs and the cost to do the program, you can see some of the economic potential when you have the upstream elements in place combined with the downstream. So just the last couple words here, and I think we'll turn to a discussion, is this model, and you've heard this from every speaker, and appropriately so, is an inexact representation of the real thing. But it does behave in many of the ways that we see in our data systems. This model does a nice job representing dozens of historical time series, which in and of itself isn't such a feat, but being able to do so with a boundary that helps leaders see how their health system can become more integrated, more interdependent, and more subject to the contributions of diverse stakeholders rather than just relying on one set of leaders. So in using a tool like this is not the only way to think about a regional health system. It's got a deliberate boundary to have a place-based wide-angle view so we can think about health and care and cost and equity and productivity all in the same sort of arena. To do that, we do it with a time horizon that helps us see not just the first 5 or 10 years, but play scenarios out long enough to give them a chance of having a fair assessment of when the yield may come. That time horizon in this model is 25 years, which has a downside to it, which is we're not looking at full life courses with this tool. That'd be another kind of challenge, a different representation. work that could be done. We're also dealing with a relatively high strategic level of aggregation. If you want to delve into the details of exactly which behaviors could make the difference here, now we migrate to another kind of tool and start to think about, once we get the idea of where the strategic priorities are, we can get into tactics and specific portfolios later. And naturally, there are uncertainties in all of this work. The point is to surface those uncertainties, and we implement this online in a software. We spend as much in building models, actually we spend more in rendering them accessible to diverse stakeholders, and that means giving people at their fingertips the ability to run these scenarios, but also to change assumptions about effect size, time delay, cost, all over pretty wide ranges, so people can see when these uncertainties would ever change their feelings about the policy agenda that they want to pursue. Tests of over-reliance, we and many of the users are justifiably concerned about both extremes. We don't want to have over-reliance on a model that is imperfect. On the other hand, we don't want to under-rely on our own, on these sort of analytical tools, and in doing so, overemphasize our ability to think through the complexity of a health system that is notoriously flawed. So my last comment about this is that we've looked very carefully about the conditions under which models can help leaders and groups make big breakthroughs in their practice. And it's very rare for a model in and of itself to drive change. It really is best done when it couples with a sense of strong stewardship, people who come to the table thinking of themselves not as leaders of their own institutions or thinking of their own narrow self-interest, but recognizing that they are part of a system that we all depend on, and somebody's got to lead on behalf of the whole, and working through the economics of governing common resources is a big part of what we understand stewardship to be. And also, having a sound strategy and the muscle to enact it means very little if you can't gather the resources to direct to those priorities. And so stewardship, strategy, and financing are really a powerful combination if they can be combined, and that's really what we're trying to do with this tool for the most part. So I will stop there, and we can engage in whatever break and questions, whatever.